A warm good evening to all. Thank you for coming. I know you could have done so many different things today, but you chose to be with us. Thank you for that. I am Vashti Watson. I'm a registered professional nurse in women's health, and I work for Kings County Hospital right here in the neighborhood. Today, my role is just to tell you the reason why we thought it was so important to have a symposium such as this. This has been a collaborative effort. Three entities came together: BACA, CAMSA, and Barbados Nurses Association of America. It was so important to us that we decided that we should share some of our knowledge and get the experts to tell us how to do things better. We realized that irrespective of socioeconomic background, insurance, culture, geographical location, there were barriers to care. Barriers are access to good care, especially in cancer. How we were going to take care of that, we didn't know. So the experts today are going to give us the knowledge that we need, or the evidence based upon their research that we need to start a dialogue or to start looking at ways that we can improve the quality of life of those who do get cancer. It's a scary time when that does happen, and the older we get, the more chances are that we could succumb to cancer. However, I don't intend to do too much talking because we need to hear from the experts. However, a little bit of housekeeping. Can we be very respectful and turn our cell phones down or in a vibrating manner? It is also very important that we listen, and there's be a lot of times for question and answers after. I must also apologize. Dr. Brathwaite is unable to be here, but Ms. Marcelle Kennedy, Vice Chair of BACA, can you please come?
Thank you, Vashti. Good afternoon, everyone. As Vashti said, I'm Marcelle Kennedy. I'm the Vice Chair for BACA. As she said, unfortunately, Dr. Brathwaite can't be here with us this afternoon, but we're always here because of her good work and her making it possible for us to be here. So BACA, the Nurses Association, and CAMSA would like to thank the leadership here at Kingsbrook Jewish Medical Center, the CEO, Ms. Linda Brady, for having us here in this room and all that the staff has done to make it possible for us to be here. Again, we hope you will enjoy the seminar, and thank you so much for coming. I introduce Honorable Lennox Price to bring your few words.
Thank you very much, Marcel. Canon Armstrong, distinguished presenters, fellow Barbadians, adopted Barbadians if there are any, good afternoon. I welcome this opportunity to be in the company of such a distinguished group of caring and concerned individuals. Therefore, let me begin my remarks by extending very warm wishes to you, and I do so on behalf of the Barbados Consulate and the other members of Team Barbados here at New York. Let me, at the outset, state that we at the Consulate are indeed very mindful and ever so conscious of the outstanding work that BACA is executing in this part of God's vineyard. So let me commend you for all the work that you have been doing, and I do urge you to continue in this vein. This event speaks volumes, and I must commend BACA, the Nurses Association, and CAMSA for collaborating on yet another occasion. This is indeed, very good and helpful that members let's say, organizations in our community to come together to work on behalf of Barbados. It is quite evident that cancer is no respecter of persons. Therefore, we have to be ever so mindful and cognizant of the preventive measures that are at our disposals. And I'm sure that this forum should address some of those concerns. The topic to explore barriers to cancer care from the Barbados and US perspectives. I do look forward to hearing the presentations. I'm sure at the end of this exercise that we should be wiser than when we first came here. I realize that we are pressed for time, and I was asked to just say a few words, and I think I have said more than a few words. So at this time, I will close by saying that I do admire and the organizations that really have planned, organized, and finally executed this event. And I do hope, as I said, that at the end of the exercise, that we will be able to educate and enlighten others about this dreadful disease and ways and lifestyles that we can adopt to prevent such from occurring. So at this time, thank you for inviting me, and I do look forward to the presenters. Let's do the presentations.
Thank you, CG. Honorable Consul General Lennox Price, distinguished faculty, President of the Barbados Nurses Association, Joan Cumberbatch, one of the collaborators here, and Dr. Brathwaite, President of CAMSA, can't be here today, but she sends her apologies. Colleagues, friends, welcome. This topic, barriers to cancer cure, is a very critical one. And in fact, the Institute of Medicine just recently put out a statement with respect to issues related to barriers to cancer cure. You'll hear more about this, when Dr. Chatrani presents later on. I'd like to segue right into the discussion by having some, case studies, we can call them, or perspectives for you before we have our major speakers present. The first case I'd like to present is actually one that I was involved with. March 2012, BACA receives a call from a Barbadian saying, my daughter has been diagnosed with acute myeloid leukemia, and there's no capability of treating this in Barbados. Well, certainly you can get the initial treatments done, chemotherapy, etc., but the bone marrow transplantation that would be necessary to treat her wasn't available in Barbados, so he was seeking help for his daughter. Middle class, family, insurance to the tune of 500,000 US dollars. That was what the policy, stated. And so I called my hospital, the authorities, Sequoians Children's Medical Center at LIJ, and presented the case to them, and they said, the insurance is not enough to cover the treatment, and we can't take her. The international office actually made this decision. Each of these hospitals have an international office that makes a decision about whether or not somebody's going to be admitted to be treated. So then I threw the ball into the court of CAMSA, because two of the CAMSA members were the faculty at Columbia Presbyterian, one in the division of pediatrics and one in allergy. And they both knew, and I also knew the chief of pediatric oncology there, and because actually he was one of my mentors when I was a resident there. And he said, fine, we'll take the kid. He knew what the insurance situation was, but he didn't really care. And she went there for initial evaluation, and it was agreed she would be admitted the next day. And she showed up the next day with her family, And while they were actually in his office in the process of completing all the paperwork, the international office representative walked in and said, she's not been admitted here. She doesn't have enough coverage. And of course, the family was very devastated. So then the ball came back into BACA's court. And then I called St. Jude's Hospital and said, here's the situation. And they said, okay, send her down. Okay, we'll take care of her. We'll fly her down to Memphis, and we'll pay for one parent to come down to Memphis as well. And we'll put her up in our housing there, and the family in the housing at St. Jude's while she's being treated. We'll accept whatever insurance she has, and whatever excess monies are necessary, we will cover. And so said, so done. She was flown down to Memphis in a couple of days, was admitted, spent about a year there, had one bone marrow transplant that failed, and the second one that was successful. Had some complications, but is okay now. Is back in Barbados at the moment, and she has some kidney problems, getting dialysis. But that was an example of access issues and barriers to care, both at the other end and here. So that's something that I think that we're going to be exploring later on. The second presentation then is going to be from Omar Salgado. Omar is actually practice manager at my medical group, Select Pediatrics in New Hyde Park. And Omar has a wealth of experience, in fact, with respect to cancer from the billing side. Omar was the head of billing for the Nassau Hematology Oncology PC in Long Island before he joined our group and became our practice manager. And he has a perspective from that standpoint, but also from the standpoint of his father having had cancer and dying of cancer. So let's welcome Omar Salgado.
Good afternoon, everyone. I'd like to thank Dr. O'Neill Paris for having me here today to be able to speak to you in regards to my experience with cancer and treatment in patients on a billing perspective. I was first introduced to the world of oncology at a very, very early age. My mother was a data manager for Montefiore Medical Center in the Bronx, and she worked under Dr. Glukop and Dr. Warnick, and her experience would transcend into the home as well. And what would happen is it was a very difficult thing because she would follow patients under new studies, studies that are now more well known now today, but at that point we're talking 1980, 79, when the research was really minute and strong. So basically, later on, I kind of followed in her footsteps, not in the same capacity, but I also worked in Montefiore Medical Center for about 9 years as a medical biller. And then I was then gone to Nassau Hematology and Oncology PC, where in a private setting, private practice, it became more personal. And I decided myself to do whatever I could to help our patients because the insurance companies were not doing what they had to do. They were not giving people a chance. They were not giving people the opportunity to get the type of treatment that they deserve. I remember doing hundreds of appeals, constant medical necessity letters, through my physicians that I worked with to get certain treatment. As you can imagine, these treatments cost thousands of dollars. I mean, if I remember, Taxotere was for one treatment like $30,000 at that time, and these are astronomical prices. It became even more personal when in 2009 my father became diagnosed with intestinal cancer. We went to the hospital. He had some stomach pain, and then after they did a couple of tests, we got the results. And being that me and my mother were very familiar with the terminology, it was very heartbreaking for us to see what was happening to him. 8 months later, my father lost his battle to cancer at 61. I was very hardened, very bitter at the time, didn't really want to be involved, but I had to be involved. I had to take the extra step. I feel that in this arena, you need people that are compassionate. You need people that are, that can really understand what a person is going through, especially when they don't have the coverage. It was through the grace of God that my parents did have the type of insurance that they needed to get the type of, treatment that my father needed. But even with all of the advancements, all of the treatment, everything that was privy to him, it still wasn't enough. And the main thing was my father was a little old-fashioned, never wanted to go to the doctors, never wanted to, really be, have checkups, so on and so forth. So I believe that had he done that, had he followed up with his physicians, had he been a little bit more diligent in doing so, this is something that we could have fought a lot better. And but in regards to my experience, they definitely don't give us a fighting chance. And in order for us to get the chance that the chance that we need people in place to to fight for our families and friends that are undergoing this horrible disease. And I think the number one thing that we need to do to help in this situation would be to stay on top of our health, try to always take the preventative methods possible in order to not even get to that point, as much as possible. I just want to thank everybody for having me. Again, Dr. O'Neill, thank you very much.
Thank you, Omar, for sharing that with us. Appreciate it. There's a report from the Institute of Medicine that just came out a couple of days ago. I'll read a few of the sentences that are in the report. The rise in demand for cancer care, a shrinking provider population, growing healthcare costs, and an increasing complex disease are creating a crisis in cancer care delivery. Therefore, a new course for cancer care needs to be charted that better coordinates care and improves data collection on outcomes and quality. And listen to this one. Most clinicians caring for cancer patients are trying to provide optimal care, but they're finding it increasingly difficult because of a range of barriers. That's what we're going to be talking about. Next case presentation, or let's say sharing, will be Diana Cadogan, who is a member of BACA, and she is actually our financial officer. And Dan is going to share her experiences over the past several years. Very brave, very committed. Diana?
Oh, hello, everyone. I'm grateful to be here this evening, to be able to share. I'll tell you my experience about the whole healthcare insurance situation. Since I've been 19 years old, I had a healthcare plan, employer-sponsored healthcare. And I used it for my yearly tests, my yearly physicals, and then 23 years ago when I had my child. And that was the only time I've ever had to really use my healthcare. But you never know how good a plan you have until you actually have to use it. And that's when I discovered, when I was first diagnosed with breast cancer, 2007. Had health insurance, but just getting the tests and everything else, it seemed like it was just a problem. Everything, it seemed like the doctors always had to be, insisting on, the test has to be done, whatever. It was a struggle. However, my doctors were very, aggressive, and I was able to get all the tests that were necessary. And I had co-payments, insurance, but my co-payments ended up, there were a lot of things I had to pay out of pocket. But I was grateful that I had insurance to cover the big things. One of my experiences during my first bout with cancer, I was on a 8 session, I had 8 chemo sessions. And during that time, I was required to take the drug that some of you may be familiar with, Nuprin, which helps to keep your immune system going. And my medicine was usually delivered after every treatment. The third treatment, they would call me to verify my credit card information before it was delivered. On my third treatment, nothing came. So I called the doctor to find out, had it not been ordered. And my nurse was, of course it was ordered, and she called them, blah, blah, blah. Next thing, they said they had contacted me, the pharmacy, and they didn't get me. So therefore, they did not deliver my medicine. And I'm saying, if I needed this, if this was life, if this had to keep me alive, I would not have gotten it. Anyway, they made a big fuss and blah, blah, blah. She called and screamed and hollered. They called me, got my credit card information, but they had it for the 2 previous deliveries. So I asked them to change it. Thank God I was able to get a pharmacy then that would deliver and bill me, or I could call back in my, So that was done. But that was just one of the things that just seemed so simple that because of a $20 copayment, I was not going to get my medicine. That was my first, and I had insurance. They were being paid, I had insurance, but that $20 copayment was stopping me from getting my medicine. Anyway, I went through that and everything was okay. I did for 5 years. I was fine. Lost my job. Had no insurance. This was last year. I was diagnosed with cancer of the esophagus. I don't know who gets cancer of the esophagus, but I had cancer of the esophagus. And I had no insurance. What do you do? The hospital I went to, and I was grateful for them, they put me on a plan where I could get tested. I would pay a co-payment every time I went. Every test I paid, I was like a $15 co-payment. I got tested, but the bills would come. At least for me in my head, I was getting the tests, I was getting what I needed to do, and I would get treatment, but I would have to worry about the bills at a later date, and that's what I did. And anyway, I was able to get what they call Medicaid, emergency Medicaid for a 6-month period, for after I was diagnosed, for the 6 months that was last June until November. So I was able to get all the treatments I needed during that time. After November, I had no insurance, but I still needed to have all the various tests, PET scans and endoscopies and all kinds of scans, and I had no insurance. But I was able to get the tests because of my affiliation with the hospital. I'm still being billed for those tests, okay? But I was able to get the treatment, and I've got my payment plan set up to do, to pay for those. Earlier that was November, I was done with the treatment. I had a PET scan in February that I had to pay for, because I had no insurance. I started a new job in January, no health insurance. And I needed all these tests. But fortunately for me, like I said, the hospital arranged, I would just pay the $15 co-payment, and I could go get the tests, but I would be billed, I'm still being billed for these tests, and the bills are big, okay? But I knew I was still getting my tests. During that time, I was diagnosed again with another breast cancer in June, just past June. No insurance. And because of my diagnosis, I've been diagnosed with 3 different kinds of cancers. This is not a reoccurrence. There were 3 different kinds of cancers, and it was suggested that I take that, the genetic test. I have no history in my family. There are no women in my family that I could find that have had cancer. If there are, they went back to the 1800s, okay? And so it was recommended then that I get that test. Insurance don't pay for, most insurance policies don't pay for that, and I did not have. Fortunately for me, I happened to be in a situation where the fact that I was working was good. And then after my diagnosis, they read all my the 3 different cancers and whatever else. I seemed like a good candidate for the test. And when I spoke to the genetic tester, she said one of the reasons they accepted me into the plan without me having to pay, because I went through a little whatever, they made me sign up this thing. It was as a test because they said that BACA test, that's the Angelina Jolie test, okay? Because everybody is familiar with that. I was told that most of the women tested, like 90% of the women tested are Caucasian. So there not enough of a feel of other women, non-Caucasian women, to really do a really good study. So I happened, because they were working on something, so I happened to be not Caucasian, and I was able to get into part of that. So that's how I was able to get that test. Turned out that I tested positive for the BRCA one. Anyway, that's a whole nother story. But I'm still standing. Anyway, and not having health insurance, but it was kind of weird, because I'm saying I don't have health insurance. I have a job. I make more than the minimum for Medicaid. But because I had a job and a couple of little assets or whatever, I qualified for some kind of American Cancer Society and Medicaid and whatever. I qualified for a program that now has given me coverage for a year to cover my cancer treatments. Okay? So I had my surgery in August 1st. I started my chemo treatment Thursday. And I'll have my insurance plan for a year. So for me, I've been fortunate. There were some struggles, but I've been fortunate, and I'm very, very grateful for all that's been done. And that my barriers have helped me. I've seen now what can be done, and there is help, but we have to look for it. But I just want to say that I am grateful I'm doing well, and I am grateful I've got the best friends and family in the world. I'm grateful. Okay? Thank you.
Thank you, Diana. I must caution you folks not to hug her, please. We don't want to get her infected. She's had her chemo, and she may be a little bit down on her immune system, so just stay away if you're coughing or you have any transmissible diseases. As you know, this symposium usually pairs a clinician from Barbados and one from the United States, so that we can get both perspectives and we can see where, we can gain knowledge that might be helpful one way or the other to either side. And this is no exception today, and I'm happy to welcome two clinicians here, Dr. Vikash Chatrani, Dr. Camille Reagan. Dr. Chatrani is going first. He's a Bayesian, and he's a graduate of the UWI School of Medicine. and then he did his doctorate of medicine. It's a different system, by the way. The MBBS, that first degree, Bachelor of Medicine, Bachelor of Surgery, and then he went to do his Doctor of Medicine in OBGYN. Currently, he is on the faculty at UWI, the Barbados campus of the medical school, and he's a gynecologic oncologist there, and holds the post of associate lecturer at the UWI School of Medicine, and is clinical director of the Barbados Cancer Society, which is an NGO in Barbados that I think many of you know about. And he's also the vice president of BAMP, the Barbados Association of Medical Practitioners. And he's going to tell you a little bit, I think, about the Healthy Caribbean Coalition, which I think he's going to use that as a takeoff point for his discussion on barriers to medical care in the Caribbean. Welcome, Dr. Chatrani.
Good afternoon, ladies and gentlemen, fellow Barbadians, the Honorable Mr. Price and Dr. Paris. So it's a very intimate audience, and because of that, I'm not going to allow anybody to sleep during my presentation, so you may be called upon at any time by just a point of a finger. So that's to keep you all guys awake. And my presentation is going to be this afternoon on access to cancer care in Barbados. And yes, there are many barriers. Coming back to Barbados about 11 months ago, having finished my fellowship in gynae oncology, I firsthand experienced these barriers. When I say I experienced them, I'm the clinician. But when my patients can't get care and they have challenges getting care, then it affects me. Because to them, they're just not only patients. They're somebody's mother, somebody's sister, somebody's relative. And if they can't get care, I can't do my job. Okay? So thank you, Dr. Paris, for having me here today. And he mentioned earlier on the Institute of Medicine. They have quality care guidelines, and it demands safety, efficacy, timeliness, a patient-centered approach coordinated by a multidisciplinary team, and the integration of evidence-based practice continuously improve care. That's a lot of words. The first two slides I have a lot of words. After that, you're not going to see any words at all, okay? Now, I'm actually going to use the Institute of Medicine's guideline to target where there can be challenges in access to cancer care. And a comprehensive aspect of cancer care without essential services targeted at reducing cancer risk. So before you even get cancer, looking at early detection, prevention, risk reduction, clinical trials, treatment, psychosocial care, and survivorship. I think if we look at each of these individually, we can see all the barriers to and the challenges in accessing care. Now, to cover all aspects of cancer care and make it practical to you, the audience, I decided to choose one cancer and highlight the services available, whether it be prevention, early detection, radical surgery, chemotherapy, and see how this compares to the standard defined by the Institute of Medicine in 2010 with respect to safety, efficacy, timelessness, and a patient-centered approach. And that cancer that I chose was cervical cancer. Who gets cervical cancer? All women are at risk of cervical cancer. And why I say that, for those who don't know, I mean, we assume that we know, but sometimes we don't know that we don't know that we don't know. This is a picture of the female reproductive system. You can see the uterus, the fallopian tubes going off at the side, and the ovary. And the cervix is that neck, or the neck of the womb that divides the vagina from the uterus. Its job is to keep the baby inside the womb. Its job is to open up during labor and open up to 10 centimeters dilatation to allow the baby's head to come down into the vagina and deliver. That's its major role. Yes, it does produce some secretions of sexual activity, and yes, that's the area that we do our pap smears. Okay? And if we're looking at the comprehensive aspect of cancer care, I'm going to speak to you about prevention first. So no longer is an apple a day enough to keep the doctor away. That's what they used to say, an apple a day keeps the doctor away. Things have changed. And that's actually a very valid point. See that cell phone there? A random poll. That was actually planned, huh? So it wasn't his fault. How many of you here have a cell phone? Just raise your hands. You're saying everybody. I'd say at least 95%. Okay, good. Nearly all of you. And I'll explain why I asked that question after the next two slides. So that was a key prop in the audience, okay? I don't want to tell you now, but most of you all put up your hands, right? Good. Prevention. So when we're talking about prevention, how do we prevent cancer? Well, to prevent, you have to understand the causative factors. So we know smoking can increase your risk of lung cancer because cigarette smoking contains carcinogens, those things that cause cancer. So health authorities push no smoking campaigns, they place high taxes on tobacco products, and they implement laws to ban smoking in public places, and from the companies putting out smoking ads targeted towards our youth. Makes sense, right? Because at the end of the day, the governments have to pay for the health care, right? They have to pay for the loss of productivity to someone who gets cancer. Barbados is no different. They have followed suit. They have no smoking laws. You cannot smoke within 10 feet of an edifice. They have bans on, the Healthy Caribbean Coalition has actually been the pioneer. They have bans on ads, smoking ads, advertising products. Now, when you talk about cervical cancer, how do we prevent cervical cancer? Well, before scientists actually knew what caused cervical cancer, they were able to identify women who are at high risk of getting this based on analyzing the demographics of the women who developed cancer of the cervix. And they found that women who smoked, had an early sexual debut, multiple sexual partners, and a history of sexually transmitted infections were the ones getting cervical cancer. And these risk factors led to stigma being attached to cervical cancer and prevented women who developed cervical cancer from opening up to their friends and family and encourage awareness and screening, and it made them hide the condition. And just the ability to share the experience can improve education about the condition, increasing awareness and stimulating other women to get screened. So there was a taboo with cervical cancer. And if you'd imagine if smoking causes lung cancer, early sexual debut, multiple sexual partners, then you'd imagine that no sex prevents cervical cancer. That's not practical. And then came the discovery of the human papilloma virus as the main causative factor of cervical cancer. This discovery won a Nobel Prize. Anyone who is having or has ever had sex can get HPV, the human papilloma virus. And HPV is so common that nearly all sexually active men and women get it at some point in their lives. This is true even for people who only have had sex with one person in their lifetime. Understand that. So you didn't have to have multiple sexual partners. And don't think of HPV infection to be like HIV, because whenever we hear virus, we hear it's common. It's so common, I akin it to the number of persons who own a cell phone in this room. And if I had asked anybody to put up their hand now if you own a cell phone, after mentioning to you how common HPV was, none of you guys would have put up your hands. That's why 2 slides ago I asked you who has cell phones. Everybody put their hands excited. I have the Android, I have the iPhone, you know. If I asked about HPV, you wouldn't have seen it. It's a very common infection. Now, how do you prevent HPV? Well, just to make you all feel better, the majority of HPV infections resolve spontaneously, do not cause symptoms or disease, but is the persistent infection with specific types of HPV, more frequently the high-risk types, lead to precancerous lesions. And if untreated, these lesions may progress to cervical cancer. So that's what leads us to prevention. Based on the etiological link between persistent carcinogenic HPV infection of the cervix, they're now giving the HPV vaccines. And these vaccines are going to be available. They are available in Barbados in the private sector, but the Ministry of Health will be implementing a national cervical vaccine policy encouraging all girls entering secondary school to be vaccinated against the HPV virus. And that's a form of prevention for cervical cancer. And just like mumps, measles, rubella, if you are vaccinated against something, your body already has the antibodies to help fight off the infection before it can cause disease. And this is not an inexpensive venture. And it's good to see Barbados will be championing this cause, and it's probably one of the first islands in the Caribbean to offer free HPV vaccines to its population. Whether the economic strains we have been experienced still allow for it begs to be answered, but my sources tell me the vaccine's already on the island. It's supposed to be launching in a month's time. So whether they've paid for it, or haven't paid for it, or can't pay for it, at least the first set will be getting the vaccine, so that's a good thing. But there are challenges, there are barriers. And barriers don't don't only have to be economic barriers, they can have other barriers. The church is a very strong organization in Barbados, and not only does it have a lot of members, but it actually has a lot of influence on society. And it doesn't have to be like this. Getting the HPV vaccine does not mean you're promiscuous. The stereotype for cervical cancer was before. It's no longer the case. Social conservatives are there. And when they hear, my daughter has cervical cancer, they hear, what? She's had sex? Multiple partners? And it's only recently have we seen celebrities come out there and talk about their cancer experience with regards to HPV infection. On the left is Franz Dressler. I'm not sure if you all recognize the nanny. She came out. I was at a conference in Chicago in 2009, and she was a keynote speaker talking about her experience with cervical cancer and HPV cancer.